Hello and welcome everyone to the third session of the ICC Crack the Wellness Code Heart Health Forum. And a warm welcome back to the viewers who participated in part one and part two of the series, where we highlighted the problems of heart disease, particularly amongst South Asians. We've covered topics related to diabetes, hypertension, coronary artery disease, the etiology and management, prevention, etc. But this evening, the focus is going to be on heart failure. As the slides were playing when you listened to this music, I'm sure you looked at the magnitude of this problem. 25 million people affected by this condition, and it's important that we spread the word so that you have a better understanding of the problem in terms of diagnosis, prevention, treatment, and long-term management. And this would also include some topics related to readmission of these patients after undergoing heart surgery or treatment of heart attacks in the hospital. So I'm Dr. Srinivas Ramachandra, a vascular surgeon by profession, a CWC doctor patron, and I am honored to be your host this evening. So let me extend a warm welcome to all of you again. And as I mentioned earlier, the slides displayed talked about the objectives of this evening's program, which is to help you understand the condition of heart failure. And we have two eminent cardiologists who are going to educate us all about this particular problem. Now, all of this comes from CWC. For those of you who are not familiar with CWC, this was the brainchild of three people: Dr. Pankaj Vij, Mr. Naren Bakshi, and Somnath Chatterjee, who put this team together, and it's comprised of 17 doctor patrons, along with the help of over 100 physicians who are involved in programming and giving talks and educating the public in this area. And they're also ably supported by the Indian Physician Association, that is AAPIO, and with also support from the South Asian Heart Center. CWC has been in existence for a little over 3 years. And the programming is such, we started off in a small way in the Bay Area. Now we have active participants from over 20 countries, and we have over 200 volunteers who help assist us in putting these programs together. And so far, believe this or not, we've had over 135 events, purely educational, where we highlight programs especially pertinent to the South Asian community. And I would invite you all to access our website, which is crackthewellnesscode.org. And if you want to actively volunteer and be a part of this whole enterprise, or this whole movement, there is another website, info@cwcicc.org, and I would encourage you all. And again, none of this happens without a lot of financial support from a lot of people. We're ably supported by a lot of doctor patrons and other patrons in the community. And we invite you to consider donating towards this cause so that we can continue to expand and be a much larger force than we are. In CWC activities, the first person, and both good friends of mine. The first one is Dr. Sam Suri, who is associated with the West Coast Medicine and Cardiology Group in Fremont. And he's been in practice for a very long time. And he's also an MD associated with UCSF and Stanford within their network. And he has vast experience in this area. And joining him is Dr. Anjali Gulati, who practices out of Good Samaritan Hospital and also El Camino Hospital. And she's an invasive cardiologist. And in her spare time, she's an entrepreneur. She is the founder, CEO of an electronic medical record company called IMD. So Without further ado, let me invite our speakers. So I invite you to sit back, relax, absorb all of this. If our cardiologist would permit, have a glass of red wine. And, just so you know, I'm sure you'll have 1,000 questions come up as you listen to our speakers. Jot down some of these pertinent questions. There will be a very interactive Q&A session at the end of their talk. So let me have the pleasure of inviting my good friend, Sam Suri.
Thanks for the fabulous introduction, and I do appreciate joining our wellness group here, and it was very well put together today by a group of our colleagues. I'm going to dive directly into congestive heart failure, giving everybody an overview and then leading up to management and therapeutics without sort of getting into details of all of this, because it's a very broad topic, very difficult to do in 15 minutes, but I'll do the best I can in a shallow dive. And most importantly, I think you'll enjoy Dr. Anjali Gulati's videos because they will be enlightening to follow. So I'm going to jump in with the first slide. What is heart failure? Heart failure essentially is a term that we use when, technically speaking, there's not enough oxygen consumption or delivery to the heart. And then also there is fluid accumulation. And we can go into the details of it because I don't want to belabor you with all the terms. So first we have to recognize what it is, fully understand what it is, and try to improve our wellness approach, as well as our dealing with it from a multidisciplinary angle. And then eventually, if we don't understand sickness, we're not going to be understanding wellness well. So we really have to understand the disease process itself, deal with it, and then how to kind of change our thinking behind this whole strategy of wellness. So the contents of my program include scope of the disease, the epidemiology, the basic diagnosis, management, and some novel treatments, which I will not belabor you on. So the burden of heart failure, as Ram had mentioned, 25 million people, number is going to rise. It sort of doubles every 8 to 10 years, and there's unfortunately, more people that are hospitalized, and we want to reduce that. Mortality from heart failure after diagnosis in about 5 years is about 50%. And that's quite significant. And there's a huge economic burden of heart failure around our communities, not only in the local hospitals, but also in the outpatient setting. So there's definitions that we sort of get into. There's kind of a busy slide, and there'll be a few other busy slides, but I will try to simplify it. So heart failure, essentially, as I said, there's not enough oxygen delivery to commensurate with the requirements of the tissues or the metabolism. And then the pressures can vary up or down depending on the kind of heart failure we have. So heart failure relates to something that we define in simplistic terms as a pump function of the heart. So if it's a normal pump function, we call it preserved ejection fraction. Ejection fraction is the amount of blood that is ejected per second. And there are certain ways to calculate that by echocardiography that Dr. Anjali Gulati will sort of explain a little bit more in her talk on videos. But then there's the non-preserved ejection fraction, which is called reduced ejection fraction, where the pump function is in disarray and the heart's not pumping well. So we calculate a number less than 49 to be a more kind of impaired function. And then there's other terms, left heart failure, right heart failure, and so on, which I won't get into because in the interest of time, it would be rather difficult to kind of go over this. We can do that in the Q&A. The diagnosis of heart failure can be difficult, but essentially in terms of awareness from a patient's perspective, in terms of the symptoms, shortness of breath is the cardinal feature when people get short-winded or short of breath with either mild exertion or even at rest. Fatigue, tiredness in conjunction with some of these, it's not just being fatigued causes heart failure, it's a combination of symptoms and a syndrome. Reduction in exercise tolerance is a very important point to remember. And then a lot of people say, well, my ankles tend to kind of swell, or I can't exercise like I did before. Those are things to be sort of be vigilant about in terms of heart failure in itself. Now, classification, and again, complicated slides, but I'll try to simplify it. There's the American College of Cardiology and American Heart Association on the left side, which talks of the screen, which talks about stage A, B, C, and D heart failure. And then there's the New York Heart Association classification on the right-hand panel of the slide, which talks about class 1, 2, 3, and 4. That's a New York Heart Association, also adopted by the Canadian classification and also by the Indian Heart Association. So that being said, however you stage it, stage A is when people have absolutely very minimal symptoms for heart failure, and they can exercise a fair amount without getting tired. Stage D is when you have on maximized medical therapy having symptoms even at rest, and B and C are in between. Same way, 1, 2, 3, 4 match A, B, C, D. Multiple causes, as you can see, and I'm not going to belabor you on all the causes, from congenital to cardiac arrhythmias to outside the heart disease called pericardial heart disease, or high output states, which are very common, by the way. Anemia is a big contributory factor, as is on the myocardial front, coronary disease, hypertension, and a weak heart called cardiomyopathy. So I will jump into the next slide. It has a detrimental effect, and this is an important slide for all of us listening in, that the quality of life really gets messed up. You know, people get depressed. There's mental problems with hostility, anxiety, because it's a chronic condition. And there's limitation to daily activity, which is very, very important in terms of trying to lead a reasonable life. Reduction in sexual activity, and then disruption from work, because people get short-winded all the time and you just can't focus in your work, and that's a real problem. And then in terms of comorbidities, any of these diseases that has been outlined here and also talked about by Ram just before this, diabetes can contribute to this, hypertension, chronic angina, kidney dysfunction, gout, hyperlipidemia, iron deficiency, anemia, and then even disturbed sleep, obstructive sleep apnea, for example, can contribute to it. So I'm going to jump into the next slide here, next slide group here, which talks about the prevalence and then diagnosis. The diagnosis of heart failure is based on a staged process. You assess the risk, you diagnose the patient. I'm talking about it from a cardiac and a non-cardiac perspective, from a doctor's perspective. You detail the workup, and then you you figure out the underlying cause or etiology, as we call it. And that's done by basically clinical assessment, biomarkers, a BNP, which is the brain natriuretic peptide, which is released from the heart, interestingly, by the stretch of the heart, whether it's the right side of the heart or the left side of the heart, particularly the left side of the heart. That marker is very important and critical in diagnosis of heart failure and in follow-up. Echocardiography, stress test, and so on. There's multiple other ways to diagnose. Cardiac MRI has become a very important tool in diagnosis of certain types of heart failure. And then there's invasive testing, which I won't belabor you on. So diagnosis essentially depends on a number of factors, and BNP measurements can certainly help in diagnosis. So morbidity, I mean, this is an important slide, relative what I shared with you earlier in terms of how do you reduce fatigue? How do you reduce breathlessness? How do you reduce hospitalization? How do you improve quality of life? Those are things to be sort of thought about, and we need to kind of discuss that in our Q&A sessions. And then this is probably the busiest slide I have, but talks about the types of treatment goals, from drugs in class A or stage A to stage B, where you have more drugs and now implantable devices called implantable defibrillators, to stage C, where you require remodeling of the heart, again by some forms of pacing called biventricular pacing, besides drugs and defibrillators. And then you sort of talk about the last stage, which is really cardiac transplantation and sort of chronic inotropes, as we call them. Finally, how do we sort of try to target improving life and improving some of the symptoms? Anemia is correctable, iron deficiency is correctable, COPD can be managed, although it's hard, but it can be managed. Changing habits for liver and bowel dysfunction can be handled well. Treatment of diabetes is quite prevalent now with chronic glucose monitoring and so on and so forth. depression, mental health is required in part of this management as well. And of course, coronary disease management. So the stakeholders in this, and this is a very critical slide for those who are interested in staying focused on this particular part of the presentation. Essentially, it's an interaction between the patient, the primary care physician, the cardiologist, and the heart failure group that includes a heart failure nurse and a heart failure physician. And then there's the patient's perspective, right? This is what patients sort of always sort of like to see. That's, again, a very critical piece of information for those on this call. You assess to care, and the therapies that have to be equal. In other words, they have to be sufficient, but they also have to be, patient wants treatments to be equal across the board. Better initial management of patients and self-management, speeding up recovery to help self-learning. That's important because we have all our websites to check all of that, but you also want to see you have good interaction with your providers and your clinicians. And then one of the big problems is when people bounce in and out of emergency rooms, how they're dealt with. People are often said, no, you don't have heart failure, but you actually may have it, and it could be subtle, so it needs to be well sort of sought out and be preventing hospitalizations for that reason. And these might be my last couple of slides to kind of engage you in the different disciplines again: early diagnosis, prevention, treatment optimization, education, telemedicine. Telemedicine has become very critical in heart failure management, especially for ongoing chronic care where there can be a multidisciplinary approach, but also in instructing patients, fluid balance, reduction of salt, discussion around treatment measures and other tools. Lastly, I want to talk about the Oxford Forum, which is kind of critical. I'm sorry, the slide is kind of off a little bit, but basically talks about how do you prevent heart failure, how do you ensure quality of care, and how do you promote support and empowering of patients. So those are the questions that remain unanswered to some extent, but I think that there's a continuum going on in this process. So I'm going to take it to Anjali now, who's going to demonstrate and show you some other videos that would sort of get you to the point on heart failure management. Anjali, off to you. If you have your videos, that would be good. Thank you.
Thank you, Sam. Thank you very much. That was a very good talk. To summarize congestive heart failure in a few slides over 15 minutes is a huge task. And there is so much information, and you actually put it very concisely and beautiful bullet points. Very, very good, elegant talk. Mine is going to be trying to summarize it, and Dr. Suri has already presented the etiology, the diagnosis, the treatment, the American Heart Association classification, the Canadian classification, the New York Heart Association classification, and the entire medical personnel team that has to be involved in taking care of congestive heart failure patients. We should remember that one of the biggest reasons of readmission to the hospital is congestive heart failure. And coronary artery disease is one of the leading causes of death in men and women. So the statistics are mind-boggling, that's a given. Now, when we say congestive heart failure, and I'm going to talk as not so much in the scientific terms, but I'm going to put the scientific with the layman term, because I think our audience is medical as well as non-medical personnel. So I will try to make it a little more simplistic. Congestive heart failure means that the heart is not pumping strongly. The heart is a pump. Actually, there are two pumps. There is the right ventricle which pumps, and there is the left ventricle which pumps. And it's phenomenal the way God has made us. It's two pumps in series, and at the same time, the two pumps are in parallel. And you would think, what physics is this? Actually, it is, because the two ventricles are next to each other and they contract together. So that's a pump in parallel. But in reality, blood comes first in the right atrium, then in the right ventricle. That pumps, goes to the left side, comes into the left ventricle, and that pumps. So the series is of the blood with the oxygenation, and the parallel is pumping together. Having said that, there are multiple causes of congestive heart failure, and Dr. Suri has already gone over them. I'm going to talk about things that we can actually take care of. So coronary artery disease, which is the blockage of the arteries, which we can do something about. So congestive heart failure, let me just go over my slides very quickly. So congestive heart failure management has multiple modalities. What is a normal pumping heart? So as I told you, heart has multiple functions, the main one being pumping. So if you look at this, you have a cross section of the heart in which blood, this is the left ventricle, this is the main pumping chamber, beautiful thickness, filling. As you can see, it fills and it empties, it fills and it empties, and it's doing it at 76 beats per minute. This is normal. So if you think about your heart, it fills you and you fill it with 100 cc's of blood. It should empty somewhere between 55 and 75, which is an optimal ejection of the amount filled. That's the place where this normal ejection fraction, that's where the word comes from. So this is a normal heart, and now this is a weak heart. Look at this. This is much bigger. The cavity, this is blood, and this is the muscle of the heart, and this is the right ventricle. So this is the left ventricle. Look at how weak this heart is. It is filling, but if you look at my hands, it fills, but it does not empty. This is what it does. It's a very weak heart. And in this one, the walls are much thinner. So if you look at these walls, they are very thin. And this is called heart failure with a weak heart, as opposed to heart failure where the wall is so thick. I hope you can appreciate that the wall is so thick and the cavity is this small. Can you all see my mouse? So the cavity is very small. So it's not that the pumping is the problem, it's the filling that's the problem. And so we in cardiology years ago used to wonder if the pumping is fine, why is this person in heart failure? So these people are called the HFpEFs. They were huffing and puffing, and they were heart failure with preserved ejection fraction. So their pumping is good, but their filling is not good. It's a stiff heart. So if it cannot fill properly, it cannot empty properly. So just for illustration, normal heart, dilated, weak heart, thick and restricted and stiff heart. All of them cause heart failure. Now, this is another view of the echocardiogram. We take multiple views. This is the pumping chamber here. This is a normal chamber. These are the valves. This is a hyperdynamic heart. You don't want a hyperdynamic heart because that leads into hyperdynamic heart failure. You want a normal pumping heart, and you don't want a weak heart that you can see over here. So I hope these pictures give you some visualization. So when the heart is weak like this, we need to use different modalities for treating it and try to make this heart a little stronger in pumping. So there are multiple modalities: medication, revascularization, devices, and prevention. So the ABCs for treatment of congestive heart failure, coronary artery disease: A, aspirin, anti-anginal agents and antiplatelet agents; B, beta blockers and blood pressure control; C, cholesterol lowering and cigarette cessation; D, diet and diabetes control; E, education and exercise. The medications, there are multiple medications that we can use in heart failure. It's a science, and then it's also an art, because you move 2 steps forward with a congestive heart failure patient with medications, and then all of a sudden you're 4 steps back because they did not know that the food they ate had salt in it. It was preserved, there was no salt that they added. So it's 2 steps forward, 1 step backwards, 4 steps forward, 1 step backwards. And that's why you need a whole team. You need a doctor, you need a primary care physician, the patient has to be involved, the patient's family has to be involved, and the nurse practitioner, they have to take daily weights, they have to watch what they eat, and the medications. So very important, multiple medications. If medications are not treating it, then you have to think of an intervention. You don't do an intervention if you can treat it with medicines and lifestyle changes. If take a look at this, this is a normal artery, this is a longitudinal axis, and this is a short axis. This is normal, lumen is nice and clear, and this is the cholesterol buildup. So 50% of the lumen has already been compromised. So if you take a look at this, this is the heart, and these arteries are on top of the heart. So they are called epicardial, which means it's on top of it. So if you take a look at this one going down here, it's red till here, then there is a clot. That's the blockage which causes the heart attack. And there is no blood going down here. And this portion is hurting, and that's the heart attack. This needs to be opened right away. So how do we revascularize? So I hope these pictures, visual effects will explain it to you. Let's focus on this first one on the top left. This is a cholesterol buildup, and this here is a normal artery. Blood is flowing down this way. So we can do, if you look at the top right, if you look at this, there is a wire in there and there's a balloon on it. We place it strategically and then expand the balloon and squish the cholesterol plaque into the wall. But if we do this, this is called plain old balloon angioplasty. This is what we used to do years ago. We still do it in some cases, but then the artery has a tendency to regrow the cholesterol plaque and also to collapse. So now if you look at the bottom left of the screen, this is a stent. So it's on a balloon, on a wire, we expand it, the stent is deployed, everything is pulled out, and the stent is left back. And this stent actually has a drug, and it elutes the drug constantly so that over here, these cells do not proliferate again. They are basically drugs which treat cancer, so they are anti-proliferation. So if you put a drug-eluting stent, the chances of restenosis, which is closure, is very small. It's less than 1%. So these are really very good. So we do this if the blockage is in one spot or two spots, or it's something that we can do from a percutaneous procedure. If the blockage is too complicated or there are too many blockages, then we revascularize with bypass. So look at the right bottom. Over here, it's a beating heart, and these red ones are the arteries. Let's say the blockage is here, up here. We add this vein, take it from the leg and plant it here. So we are basically bypassing the blockage. So in layman's term, if there is a highway and the road is blocked, the CHP comes and creates a detour and bypasses that blockage. That's pretty much what we are doing here. So the bypass is here, the blockage is here, and we are bypassing it. I hope that was clear in this illustration. So if you look at this, this is the angioplasty, the same thing that I showed you over here. You will see in the cardiac cath lab, here is the blockage. If you look at the top left, that's the angiogram, and you can see the blockage right there in the middle where the artery looks like it's been eaten away. And then if you look at the bottom right, the stent was expanded, the stent was expanded, and it's now nice and open, right? That's percutaneous coronary intervention. Now, once we do these interventions, we wait for a few weeks to make sure that the heart muscle, which, it was contracting like this, suddenly over here, the artery got compromised. So this wall, instead of moving like this, now lags behind. Think about this. You're running a race, and I take a tourniquet and I tie it tight on your thigh on the right side. Now, when you run, that right leg will lag behind. And if I tie both your legs, you will be the last one in the race if you run at all, because the legs will be so weak because there's no blood supply. Once you open the blood supply, take out the tourniquet that you have tied, the legs get circulation, and then they can run again. Similarly, when the heart has become weak because of decreased blood supply, once you do the angioplasty, once you do the bypass, whichever intervention you have done, we give the muscle time to see if it will come back. If it comes back, you have treated it and the heart has become all right and the pumping is normal. Bypass is very good for multiple vessels and multiple vessels in diabetics. Longevity of life and readmissions are much less with bypass. So it depends, the choice of the procedure depends on the patient selection, patient's criteria. Let's say the patient gets better, then you treat them with medication and lifestyle changes. Very, very important. Therapeutic lifestyle changes. However, if with revascularization, your pump is still weak, there are other devices we can use. This is called a cardiac resynchronization therapy. This is a pacemaker that's placed under the clavicle over here, under the skin, and it has 3 wires, as you can see here. 1 wire goes into the right atrium, 1 in the ventricle, and 1 goes across over here in the coronary sinus. What this device does is the heart is not pumping efficiently, and this device provides the proper electrical current, mimicking the normal physiology of electricity in a heart, which causes the heart to contract. So if you have normal physiology, hopefully the efficiency of the contraction gets better. That was the hypothesis for cardiac resynchronization therapy, and it has proven to be one of a very good tool. It's proven to be one of the good tools for improving the efficiency of cardiac pumping. Then there is the AICD. You all have heard that person has congestive heart failure, they suddenly died, just dropped and died. And then you have seen in movies where they go and give a shock outside. Well, not everybody has a defibrillator here, there, and they are not doctors present everywhere or EMS personnel. So there is the small device over here called an AICD, which is an automatic implantable cardiac defibrillator. It has 2 wires. One is here in the right atrium, one in the right ventricle. Sometimes it's a single wire defibrillator, and there are other types of it. I have just shown one here. If the weak heart suddenly goes into a ventricular arrhythmia, this small little dot over here recognizes the beginning of the arrhythmia, sends a message back to this box. This analyzes it and gives it a shock and brings the patient out of the ventricular arrhythmia, thereby preventing sudden cardiac death. So automatic implantable cardiac defibrillators are an excellent device when the patient meets the criteria, they get them. Okay, now on to a completely different one. The heart is so weak that you have now got the defibrillator, you have got the CRT, you've got all the medications, the patient is following all the classical lifestyle changes, but the patient's heart is not improving and the patient is on the transplant list. But there aren't enough transplants available, there aren't enough donor hearts. So how do we tide the patient till he or she can get their heart transplant? So this device is called a left ventricular assist device. What that means is that the heart is so weak it cannot pump, but the heart is getting blood. So if you look here, this is a small tube that's placed in this pumping chamber, and this sucks out blood, and this little device here is the pump, which receives blood from here and pumps it into the aorta. So this heart is kind of just a conduit, but this is what's doing the real pumping. So in the past, these patients had to be hospitalized, live in the ICU beds. They had a wall socket and they were connected to the battery and the source of power. Now they can move around, and I'll show you that. So you can have a single vessel assist device, a single chamber left ventricular assist device, or you can have a biventricular assist device, one on the left side and one on the right side. This is done at specialized centers, and people, when they get LVADs, they actually, their life expectancy improves by a few months. Actually, it's almost more than a year to 2 years. They can have this while they are waiting to be on the transplant list. Here is a person, now he's wearing it with a harness. So up till this point, it is inside and under the skin. From this point onwards, everything is outside. So here is the system controller, here is the battery, here is the pump. Blood comes out here, pumps up this way, and every generator and the battery source and power source are connected to it, and the person can actually walk around, wear proper clothes, and go do something. Sometimes with the LVAD, their heart actually, with the medications and time and revascularization, they get better. Sometimes they have to go on to cardiac transplant. And that's, oh, one more thing. ECMO, this is much more newer compared to the LVADs. It's called extracorporeal membrane oxygenation. It's not that new in cardiology, but relatively against all those devices. This is for patients that have gone into sudden cardiorespiratory failure. So you take blood out, and this is not going into the heart, this is in the periphery. So you take a peripheral big vein, draw the blood out, send it through a pump into an extracorporeal, which means outside the body oxygenator, cool it and send it back. You can send it into the artery. It's called veno-arterial oxygenation. It can be veno-veno, or it can be veno, arterial, and veno. So it's going back into both, but it's pulled out of a vein, sent into an artery, or pulled out of a vein, sent into another vein, pulled out of an artery, and sent into an artery and a vein. So multiple different devices. This is to tide a person over acute respiratory and cardiac shock. And then this is the one that everybody knows about, cardiac transplant. You take the patient's diseased heart, take the donor's heart, connect the superior vena cava here, inferior here, aorta here, pulmonary here, and you have a new donor heart in place. And from that point onwards, you have a lot of post-cardiac transplant care that has to be done initially at a tertiary center, but then they can go back to their primary doctor. So that's pretty much the devices. But of course, here is the summary. It's a leading cause of death in men and women. Most risk factors can be modified. I cannot stress the importance of this. Stop smoking, treat high blood pressure, treat high cholesterol, treat diabetes, lose weight, exercise regularly, eat a healthy, balanced diet, and stress reduction. Easier said than done, but all doable. So, in summary, catch the problems before it catches you. Know your risk factors, know the symptoms, modify your risks, discuss your risks of coronary artery disease with your physician. And if you feel you have symptoms, call 911. Call 911 and come to attention right away. Rather be safe than sorry. In English, there is a saying, time is money. In cardiology, we have a saying, time is myocardial muscle. If you come with a heart attack very quickly and they open it up, the muscle further to the blockage does not die, and we salvage the myocardium. So the sooner a blockage is opened, the better it is for the patient. So to sum it up, thank you for your time. Listen to your heart. It's telling you a lot. That's the love dub. Any questions?
Absolutely wonderful. Now, you talked about the various etiologies of this one, what diagnostic tests you can do, and what modalities of treatment and management there are. In the past sessions, we stressed the acronym MEDS, M-E-D-S, meditation, exercise, diet, and sleep. And you've added a few more, and you've come up with this abbreviation of ABCDE, which is wonderful. I hope everybody copied that in and would take that to heart. It's very important that we follow some of these things that were highlighted today. Now, before we jump into the Q&A session, I know you talked about how all of this eventually ends up in heart failure and what can you do to A, prevent it, and how you manage this problem. One of the things that I would like to know is, Sam, you mentioned about the cardiologist, the primary care physician, the nursing staff, and so forth. And where does the family fit into all of this? I think they would also be key players in all of this one.
Absolutely. I think they're pivotal. They're right in the center of all of this because that involves, it's a multidisciplinary approach. And the first thing we tell everybody is, where's your family? We ask the patient, do you have any family? Can we have them involved in this? Because they can be very influential in adjusting not only dietary changes or implementing lifestyle changes, activity changes, and smoking and alcohol, limitation or cessation. Those are like critical points. So if you don't, the patient alone probably is already given in because they've already accepted the fact that they've got congestive heart failure and they're on their way to, either recovery from medications or, progress of chronic disease, et cetera, as Anjali had alluded to. But if the family intervenes early and early enough, I think all of these things can be prevented so we don't have issues regarding medications or other changes that we talked about.
Great.
Yeah, if I may chip in, it's so true, Sam. It's very important because if someone's trying to quit smoking and their family member, spouse, or somebody is smoking, very difficult for them to get off.
Correct.
If the wife is cooking and she's putting salt, the husband has no chance of going on a low salt diet. If everybody in the house is having high fat diet, how long are you going to survive on salads? People try to get disciplined, but there is, birds of a feather will flock together. And if the whole house is flocking in one way, very difficult. So social support is very important. In fact, when I was at Stanford and they used to do the initial intake for the patients referred for the transplant program for congestive heart failure transplant consideration, social support and family is one of the big questionnaires. And there is a special person assigned to see in the congestive heart failure clinic to make sure that that there's enough social support. And then the nurse actually has constant contact with them every single day in the beginning, and then it becomes once a week, then it becomes once a month. But social support is a very important, families have to do it together.
Agree.
Great. Now, both of you talked about readmissions. I'm assuming it's readmissions after being hospitalized for, let's say, coronary bypass, or even being hospitalized for heart failure or heart attack kind of issues. Now, before we dive too deeply into this, we do have a special person here, which may be appropriate to have him talk about post-cardiac surgery follow-up and remote monitoring. We have Mr. Yogendra Bhomra, co-founder and CEO of Omnic, and they offer some tech solutions for this one. So Yogendra, would you please unmute yourself and tell us a little bit about your program?
This, I don't have any presentations, but as we talked about the challenges of heart failure and other cardiovascular related diseases, the post-care management is a critical aspect of it. We talked about 30-day readmission rates, which through various studies is about 20%. And if they are not managed properly after discharge, the death rate is overall of the cases is about 2.5% to 3%. The key challenges there are that once the patient is discharged, it's very difficult to know what is happening in the real life. So what we provide is a solution for long-term data collection under normal living conditions so that we can do the diagnostics and find out a long-term trend and potentially determine early markers where an intervention is necessary before it's too late. So we have a proprietary analysis based on key body vitals. Some of the things that we measure are obviously standard: heart rate, blood oxygen level, temperature. Big difference is we measure continuously, meaning every single beat of the heart is monitored 24/7. And then we do the analysis like missing heartbeats, interbeat interval-based heart rate variability. So just to find out that heart rate variability is not rate of heart rate change over time, but the difference in time between each single beat. So we have proprietary analysis where we do analyze heart health score. Over time, we provide the trends. We provide real-time alerts that to help manage and reduce the readmission rate. So that's our primary focus.
How you currently manage these patients, and what kind of telemedicine can be incorporated in?
So anybody who has congestive heart failure needs really ongoing care. You cannot just say, I'll see you in a year, or take an aspirin and I'll call me a year later. You can't. It has to be a constant, it's a lifestyle. We call it TLC, therapeutic lifestyle change, in which you have to do a lot of changes, and you have to follow the lot of parameters like Mr. Bobra has just said. So what do we do with our patients once they get discharged? The first thing we do is to make sure that we have a telephone conversation with them within a week. I give all the CHF patients my cell number because I don't want them decompensating and showing up in the emergency room. I tell them my goal here is to keep you out of the emergency room and out of the hospital. So please watch your diet. Please be compliant with your medicines. If your medicines are getting over, call the doctor a week in advance. Don't call me to say I ran out of it yesterday. And if every single day they have to keep their blood pressure, their pulse, their weight. There's a record that we actually have a congestive heart failure documentation that they take with them. That's a very standard document from ACC/AHA, you can get it. So they do it and they learn that if their body weight every morning without clothes, same time, they go and weigh themselves. If their body weight is more than 4 pounds in 2 days, or 4 pounds, actually, I tell them 4 pounds in 1 day. If your weight has changed more than 4 to 5 pounds in 1 day, I want a call that day, not tomorrow, not day after, because what that usually indicates is not that they have eaten too much, but that they are now retaining water. So I train them, watch for signs of congestive heart failure. If you now cannot lay flat, I need to know. If your legs are swelling more than normal, I need to know. If you have too much bloating, because people don't realize that bloating is not because they ate some bad food. Bloating is because they have water retention, not only outside of the body, but also in their gut. And when that happens, they get bloated, they get full earlier, so they're not eating, they don't get nourishment. And then when they take their medicines, it doesn't absorb. So at that point, they need to come in and get IV medicines so that they can absorb it. So the main things are measure your parameters at home. Now talking about, and then they go to cardiac rehab. Everybody who's been revascularized goes through cardiac rehab. It is one of the best services provided by Medicare, is that they agree for the 36 sessions of cardiac rehab, where they learn to exercise and improve not the entire cardiovascular functional status. So even the peripheral muscles, when you exercise, you're going to flush out the, you have more circulation, the lactic acid accumulates, your vessels dilate. So everything improves, the vascular tone improves with exercise. So they go for cardiac rehabilitation after revascularization or a heart attack. Now, what you said about heart rate variability is phenomenal, Yoginder. There was a paper in the 1990s, I think it was 96, 97, this article came out, and it's a brilliant article on heart rate variability in patients with congestive heart failure. And it is an individual prognostic indicator of long-term mortality. So if a person has very good heart rate variability, which means they are sitting down, they are 50 beats a minute. They get up, it is 56. They take a deep breath, it slows down. They breathe faster, it goes out. So with the respiratory function and with your functioning, the heart is able to slow down or improve or increase the rate. So it's the variability, the beat to beat variability. People who have heart rate variability, and if you're measuring it, it's phenomenal, Yoginder, because that is an single most individual prognosticator. We don't use it enough in cardiology, we just don't. But it is a beautiful indicator. If somebody does not have heart rate variability, it's a bad sign. It's a bad sign, and they have high morbidity and they have low life expectancy and high mortality. So heart rate variability is brilliant. And since this is the CWC, I am, if I may take a minute, very important. One of the things that you can do to improve your heart rate variability, you can go about it the Indian way, or you can go about it the I'm in the Silicon Valley, I need a gadget way. It's up to you, whatever floats your boat, do it. There is a thing called pranayam. If you do pranayam and you learn to do breath control, you actually decrease your sympathetic tone and you increase your parasympathetic tone, and your heart rate variability improves. You can make your heart beat faster or slower just by breath control. It is a real science and there is scientific evidence for this. So you can find a good yogic guru and learn how to do pranayam. And if you want, you can go, there is a place somewhere in the Silicon Valley, it's called Heart Math, like mathematics. You go to Heart Math, they make you sit in front of monitors, they hook you up, and they train you to modulate your heart rate, your blood pressure, your rhythm, and everything. So people who have all kinds of palpitations and things, with Heart Math, with objective biofeedback, can actually improve their heart rate variability.
That's wonderful. Sam, did you have any other comment
I
on
mean, I think,
telemedicine and how you monitor your patients?
well, I mean, it's very similar to what, a lot of other cardiologists, including Anjali, do. Basically, the key thing is to make sure that patients stay very tightly monitored, very tightly controlled, very frequently either looked at, visually on telemedicine protocols, or giving us feedback on how their day-to-day weights, their leg swell, breath, and all that is. But more importantly, I like to follow my patients very frequently. Any heart failure patient, I tell them, if you have heart failure, you need to see me once a month. That's just the way it's going to be. If you have serious heart failure, it's going to be even more frequent than that. Not just to see me, but also just to make sure they're monitored, their medications are controlled, and they are followed without getting into the hospital. Key thing is reduction in hospitalization.
Any smart watches that they wear? Any special gizmos that you frequently like to use?
So I think Yogendra, you can kind of give us a little bit of an insight. You have more technology than I have in my mind or head. So you may want to comment on that.
Yeah, what I'd like to say, the key reason you would want to use it is because what Dr. Anjali said, that the pranayama and the Indian way of doing is correct. We highly recommend it. What we are providing you a capability that they are all generic solutions. How well they are working for you, you need to have measure for it. And like you say, you need to see them once a month or once a week, or if something goes wrong, patients normally don't know what is happening. To teach them, and so much only can you teach, but our device will provide you a real-time alert for the timely intervention and care before the situation becomes severe. So those are some of the values we bring in.
So
Currently,
is your device implantable or is it external?
no, it's a wearable device.
Wearable device. Yeah.
The big difference is it's a ring that I'm wearing right now. The big difference is nobody has been able to currently do a interbeat interval monitoring on a long-term basis. Our current solution lasts for close to 3 days without charging. So you monitor every single beat and you recharge it. Our next version coming out, we will expand it to 5 to 6 days. So essentially you can think of it, you are wearing a Holter monitor for the rest of the life if you want to wear it.
So do you monitor the rhythm and the oxygen saturation and all of that?
Yes, oxygen saturation, every single beat, we find out the missing heartbeats, calculate the heart rate variability, we measure the temperature, and then we do our analysis and provide you a daily report and real-time alerts. So,
Right.
so I think that would be very helpful in identifying who potentially need an early intervention.
Great. You said you're starting a clinical trial in India.
Yes,
Yes, would
yeah.
like to see the results come out soon.
yes, yeah, we are targeting to start it in October. We will
Terrific.
recruit 300 patients who have gone through myocardial infarction procedure and follow them, hopefully determine some markers which can predict potential unwanted event of the future.
Wonderful. So, Dr. Gulati, you mentioned pranayama. It's one of the lifestyle modifiers.
It is.
Are there any others that you can employ? And do you know of the actual failure being reversed?
Oh, yes, absolutely. Lots, it's actual reversal. It's usually revascularization, long-term management, and lifestyle changes are along. It's nothing is in series. All of it is in parallel. You have to do the ABCs. You cannot just dump medications. You know, we haven't spoken enough of medications on this. Heart failure medication is a whole science and art in itself. Patients should be on aspirin if they have coronary artery disease. If they don't, that benefit is really yes, today, not tomorrow. They should be on an ACE inhibitor. And especially in the Indian diaspora, I am presuming there are lots of Indians on this forum. Indians have a lot of diabetes and they have a lot of hypertriglyceridemia, low HDL and high LDL. So in these people with their diabetes, hypertension, hypercholesterolemia, and heart failure, and even in general, you need to have them on aspirin. They should be on an ACE inhibitor. And if they cannot afford an ACE inhibitor because of side effects, because ACE inhibitors are generic, anybody can buy them. They're very, very cheap. If they have side effects, because people can have terrible that kind of a cough and they can't tolerate it, or they can have actual angioedema. So if that's the case, then we put them on angiotensin receptor blockers. And if they can't tolerate that, then they get put on isosorbide plus hydralazine. So there are multiple levels. These medicine reduce the afterload. What that means is if this is the heart pumping into this chamber, the afterload, that this actually becomes easier. So the same weak heart can pump more into that conduit. So you use ACE inhibitors, ARBs, you use beta blockers. It's a mainstay of therapy for congestive heart failure, cardiomyopathy. If it's systolic dysfunction, you use digoxin. You use a diuretic because these people gain weight. If you use diuretic, you have to watch their potassiums and magnesiums very closely. Otherwise, they can have arrhythmias. And then beta blockers I mentioned, and this is what Sam was saying. If you have congestive heart failure, cardiomyopathy, they need to be followed very closely. You give the patients beta blockers almost 25 to 50% patients will stop taking it because they get so tired with the congestive heart failure. They're already tired, and beta blockers cut off the adrenaline drive. So it's basically they block the beta receptors. So the person, instead of being like this, is like this. They are tired, they're tired, they're tired. And they get so tired, and in male patients, because of sexual dysfunction with those medicines, they toss them out the window and don't even tell the patient, the doctor. So we have to have an honest conversation with the patient. These are the medicines you'll be taking. And if these medicines give you these possible common side effects, please come talk to me. We'll find an alternative. Do not stop the medicines by yourselves. So medications, very important. Diet, very important. Salt control, important. Low fat diet, right? No saturated fat diet. And then the water reduction in congestive heart failure, cardiomyopathy with hypervolemia, where they have too much water retention, they have to reduce the amount of water they drink. So it's a really terrible situation for the patients. Think about it. They can't have too much water. They can't add salt. They cannot have any tasty, greasy food. They're usually diabetics. They cannot eat sugar. What do they eat? And sometimes they have renal failure with it. Anything that they put in their mouth has potassium, and they have to be careful. So it's very difficult, and you have to work with them. And then exercise. They can do exercise. They can quit smoking. One of the questions that you said in the beginning was about alcohol. And for the longest time, that one study, the Italian study, was a bane of, it was a real problem, because every patient that came, and especially in the Indian community, people would come and say, hey, doc, I have your permission, with 2 glasses in their hands. And the answer, there was nothing we could tell them, because there was one association study that if you drink a glass of wine, you might have low incidence of heart disease. Well, finally, the ACC/AHA guidelines a few years ago, about 10 years ago, finally took a stance on it and said that with red wine, there is one study, which is an association study. It is not a double-blinded, randomized, prospective, blinded,
Right.
ongoing study. So
But certainly the media got hold of it, and
they got a hold of it. The summary is that if you drink a glass of wine, drink it. But if you think you're going to start drinking to prevent heart disease, don't do it, because it's a very slippery slope. You don't know when one becomes 10 glasses. That's the AHA guideline.
Right. So I take it that this treatment that you outlined is pretty standardized the
It's
world
standard.
over.
It's standard.
You don't have
Yeah,
to
actually,
live in Silicon Valley
wanna-
to get access to
No.
some of the fancy stuff. But by and large, when it comes to diet, medications, and so forth, it's pretty standard.
Yes.
Correct?
Yeah.
So are there any clinical trials specific to the South Asian community that some of these patients with heart failure can subscribe to?
You want
So
to
there's
aware.
several. Yeah, I can just give you a general idea. I know I've been looking at some of the Indian medical journals and some other journals where there's been sporadic data, but overall, I think the consensus still comes from the United States, and also from the American Heart Association guidelines, and possibly some of the Canadian guidelines. So I think that a lot of this has been double-blinded, as Anjali had said, and so we adopt heart failure management based on US standards.
Right. So you may have alluded to this, but there's one question from one of our viewers about a lot of talk about reversal of blockages by diet and exercise. I know you made a mention of it. Is there a way of checking it non-invasively to
So
see
maybe
if there's some
I'll
impact
jump
from
right
your
in.
lifestyle?
I'll jump right into this, and then I'm going to pass it on to Anjali, because she has a little bit of a different perspective. But basically, how we check at this point, I mean, there's objective ways, and the single best way, of course, is non-invasive way is a stress echocardiography procedure or a stress test. That, I think, is garden variety. You know, if you have a doubt, treadmill. That's the number one thing, besides doing an EKG, which is similar to just taking a photograph for a 3-second, evaluation. But if you can functionally test them, that is the one best way to follow not only heart failure, but also to follow angina or angina equivalent symptoms as they may occur from partially blocked arteries, or the other issues about plaque stabilization, which does occur with statins, and that's been well known. But I think Anjali will tell you more about CCTA and so on and so forth, because there's other ways to measure coronary calcification and things like that.
We
And
will
that's been
save
well
that
written up. By the way.
for-
Okay,
There could
all
be
right.
a whole session on this one.
No, I'll make it very brief. I think my perspective is exactly the same as Dr. Suri's. We practice evidence-based medicine. You can do a coronary CTA, which is the calcium, and you can do calcium scoring. Calcium scoring is going to give you radiation without enough answers. If you get a calcium score that is high, you could have deposition of the calcium in the inside of the artery, outside of the artery. You don't know the significance of it. You end up doing a stress test. So I spare all my patients the calcium scoring. I don't do it. I actually do exactly what Sam does. It's evidence-based medicine. You do a stress test. If the ECG is normal, you do a plain old stress test. If the ECG is abnormal or the patient has some other issues, you do a stress echo. And if the patient cannot run on the treadmill, you do a thallium perfusion study. This is called a cardiovascular functional study. It gives you the answer that even if a patient has a blockage, what is the significance of that blockage? If you have 40% blockage, but you pass the stress test, you don't need anything further. What you need is prevention. You need your statins, you need your aspirin, you need your blood pressure control, and you need your diabetes control. But if the stress test is abnormal, then they need the angiogram. A lot of time patients come and say, my family member has it, just do an angiogram. And the answer to them is no. You do a cardiovascular functional study exactly as Sam Suri has said, you do it exactly like that. If that test is normal, then you don't get an angiogram. An angiogram is a test we do all the time, but it is an invasive test. And any invasive test, you have to be careful that the risks have to be low and the benefits have to be high. But if the risk is even 0.001%, you don't do it unless you benefits far outweigh it. So functional study, Sam, I'm
Right.
with you.
Terrific. I have to ask you.
Thank you.
I have to ask you both this question since we're in the midst of this pandemic still. What is the effect of a COVID infection on the heart, and how lasting are the effects of this vis-a-vis heart failure and recovery from this? It is especially pertinent because there is still a fair segment of the population that doesn't believe in vaccinating and doesn't mind getting the infection. Does it leave a significant deficit as far as the heart is concerned?
So I'll dive into this one, Anjali, because I did actually give a talk on this about the last time we were here on COVID and heart disease. So I'll just bring up the salient 5 or 6 points. First, COVID affects every organ. We know that. Second, besides affecting the lungs, it definitely affects the heart in a big way, directly onto the myocardial cells, which is basically the actual muscle cells, and then indirectly by causing inflammation around the heart as well. And then it also does influence and make heart failure worse in a lot of patients that already have coexisting disease. And then 4 and 5, it also can propagate in many patients who have the risk of developing cardiac arrhythmias. The arrhythmias get worse. And then lastly, their lifestyle changes that sort of get hurt as well because of the declining overall health from COVID, fatigue, and so on and so forth. So those are the 5 salient points in this. And it also increases blood clot formation, which is very serious. Deep vein blood clots and then also superficial vein clots and clots within the heart.
This is even if you're vaccinated.
Yes, vaxxed or no vaxxed, I mean, the risk is still there, and that's why we have to be careful.
Absolutely. Thank you. Any closing comments, Anjali?
For the COVID thing, yes, like Sam has put it very eloquently in 5 points. One of the issues is that so initially in the first 2-3 months of COVID, the concern was that the cause of death was cardiorespiratory, and in the heart, they said there's myocarditis, there is an increased number of thrombosis, so there is a huge number of heart attacks and then arrhythmias. But over time, because at that point, nobody knew what was going on. And, last year there have been 120 or 150,000 articles on COVID. It's like my experience, my anecdote, it doesn't work that way. So initially, CDC came out that there is more death with myocarditis, increased thrombus and heart attacks, and ventricular arrhythmias. What has panned out is a few months into the COVID pandemic in 2020, American Heart Association and Jack actually came out and said, where have the heart attacks, acute heart attacks gone away? Because the actual ST elevation MI numbers actually came down. So if they are coming down on the one hand, or on the other hand, you're saying there is more thrombosis and more heart attacks, it doesn't match. So that data is there's two separate kinds of data sets over there. Time will tell us exactly what it is. But myocarditis is a real problem with viral infections, and mRNA will be found in them. I haven't seen too many studies about it. And I heard about studies in which people who had COVID, normal young people, and this is the really scary part, they didn't have bad COVID. These are athletes. And months later, they are coming with cardiomyopathies. So I'm actually screening a whole set of patients who had COVID. We're doing echocardiograms on them, and we are actually collecting data to see where it goes. So far, we've not found any cardiomyopathy 4 to 6 months to a year after COVID, but our cohort is very small, but it is a real fear. It is.
Wonderful, wonderful. I know, we could have this engaging, illuminating talk for a very long time, but I'm afraid we're short of time, which should wind this up. I want to thank you both for taking the time and for making this complex topic and simplifying it so that everybody can understand this. Hats off to you. You both did a fantastic job.